Hello, everyone. Thank you for joining us for this HoodMed chat, another pandemic update with our good friend, Dr. Peter Hotez. My name is Dr. Neecey Hudson, and I'm the chair and science director of Hood Medicine.
And I'm Jonathan White, co-founder and director of policy, and also the one with work being done at his home. So you hear some interesting sounds during this podcast.
And I'm Doug Slaughter, the Public Health Director.
Hood Medicine Initiative is a collective of scientists, physicians, hackers, and assorted geeks focused on addressing health disparities and improving access to care in Black and Brown communities.
And our Hood Med Chats, our signature event, is an effort to bring expertise of healthcare professionals and others in those communities, others to those communities. Our goal is simple: help us, save us.
And today we are extremely honored to welcome back Peter Hotez, who is a professor of pediatrics and molecular virology and microbiology and the founding dean of the National School of Tropical Medicine at Baylor College of Medicine, where he's also the co-director of the Texas Children's Center for Vaccine Development. Glad to have you, Dr. Hotez.
It's an honor. I'm so happy to see everybody again.
And we're joined this time by Diana Stansberry, the founder and president of Project Global Impact, one of Hood Medicine's partners, whose mission is providing an idea accelerator that creates, develops, and delivers global projects with a positive impact on quality of life. She leads the international team of project and program managers who develop the Rapid Response Pandemic Unit, a modular system of testing, laboratory, and vaccination units to combat COVID-19 and future pandemics. So thank you for joining us, Diana.
Thank you so much for inviting us. My team and I are very excited to introduce the R2PU to this forum. Thank you.
So welcome back, Dr. Hotez. We've had so many updates since our last visit with you, and I want to welcome Diana as well. We're happy to have you here to chat with us about global vaccine equity.
Excellent. Yeah, lots happened since we last chatted, both good and bad. It's been a very mixed picture, of course. In the U.S. now, we are getting numbers up there overall, right? We got about 50% of the U.S. population a single dose and 40% 2 doses of the vaccine. But that's not the real story. What's unfortunately is happening, and no one's really talking about it much, is we're morphing into 2 COVID nations, because at least in terms of geography, we've got the northern states, up instead of 50 and 40% single dose, 2 dose, you got like 60, 50% in the Northeast, in New York, New Jersey, New England states, California, really the Democratic strongholds, and which is very interesting. So that's great news. So I think, that says that section of the country, we're going to go pretty far at reducing transmission. But down here where I am, in the South, not so much Texas, but states like Louisiana, Mississippi, Alabama, it's really bad. It's about half that rate. So transmission is going to continue for a long time. And also in Wyoming and in Idaho as well. So it's leaning towards a clear blue state, red state divide. It's that striking right now. I mean, bottom 10 states, all deep red states, mostly in the South. Top 10 states, all bright blue states, pretty much. New England, New York, New Jersey. I mean, I hate to say it, it's like the Union and the Confederacy.
Sure
That's how bad
Yep.
it is right now. And people say, shh, you're not supposed to talk about this. But I know how else do you address it unless you bring it out into the light? I mean, I don't know how else you do it. And so there is this pretty clear political divide now and look, it's not only vaccines, right? It's around a lot of things, but we need to figure out a way to reach our conservative brothers and sisters to convince them to get vaccinated. You got to stop this defiance. But I'm curious to hear from you, as in addition to the conservative groups that are digging their heels in, and this is playing out on Fox News at night and that kind of stuff, all the anti-vaccine rants. What's happening in Black and Brown communities? Because when I last checked in with you, vaccine hesitancy looked like it was going down. It wasn't perfect by any means, but it was a lot better than it was. But I'm curious to get, so that the problem now is more about access and awareness than more than vaccine hesitancy and refusal. But I'm curious to hear you get your input.
You know, I'm
Well,
troubled about it because now what we're seeing is all of that conspiracy hysteria seeping into Black and brown communities. So now we're fielding the same ridiculous questions about 5G and nanobots. And
Oh
it
man, really?
started
Oh, I'm
with
so sorry to hear
vaccine
that.
hesitancy, but now it's a conflation of all kinds of things. There's, you know, it is about this mistrust of the government, but also with a lack of understanding about how science is conducted in the 21st century, in terms of the oversight and regulation. You know, people don't understand that there are no mad scientists in the 21st century, right? Like, we squash that. There are rules, regulations, transparency, standards of integrity, and all of it has oversight from start to finish. And I think
And you
people,
got to maintain a funded program, right? It's hard to get
right,
That's right.
the funding stream from the Mad Science Foundation is not looking looking so good. So
and
so
yeah,
that's a lot of it as well. But you're
I don't
right.
know.
And
Marjorie Taylor Greene is getting a lot of money
oh my
to her
God.
mad political camp. So I don't know, Dr. Hotez.
Well,
I'm
but this is
not
part of it,
optimistic.
right? I mean, this is
Yeah.
all part of it. It's this right-wing extremism that's really promoting the anti-vaccine stuff, and people are wearing their defiance of vaccines like a political badge. And
Mhm.
and how do we fix that? It's so self-defeating and dangerous. And
it
Yeah.
is.
and
Well,
I'm sorry to.
one of the things going off of what Dr. Hudson said, that I think we've talked about in our previous conversations is, while we want herd immunity across the country, you know, to reach herd immunity across the country, you know, we also have to realize that these intra-community herd immunity levels are as important as well. You know, we all know that the largest population of Black folks are typically in these southern states.
Mhm.
And, you know, with these southern states not, you know, reaching even nearly, you know, close levels to herd immunity, that puts more and more Black and brown, you know, folks at risk in those states. So we have to make sure that people in those communities are protected
No, you hit
despite,
it. You hit
yeah,
it perfectly. I mean, what I'm worried is that you're going to get Black and brown communities as collateral damage from all of the vaccine defiance coming out of conservative groups. And you're right. I mean, the thing that I'm worried about now for the southern states is, you remember this, if you look at this time last year, we were also at our low point in the epidemic. Things were looking pretty good. And then if you remember, a lot of the southern states just let it rip. They said they're going to open up. And then we got that big southern surge that came across the South in the summer, right? July and August was just something awful, you know, for Louisiana and Mississippi and here in Texas. And a lot of people lost their lives. A lot of Black and brown people lost their lives. And I'm worried it's going to happen again because, you know, they got the complacency. People think we're done. That's problem number one. Problem number two, we're not vaccinating the South.
Mhm.
And you know, why, you know, we could get that surge again. Now maybe it won't be as bad because some people are getting vaccinated and some have been infected and recovered and partially immune. But I still think that's my biggest worry right now. And that's what I'm trying to sound the alarm about, is the South has a real vulnerability, and we've got to do all we can to get people. I mean, we've got to do all we can to get people vaccinated everywhere, but especially in the South right now. There's a weak link there.
Yeah. Could you put that into perspective in the context of the recent CDC revisions to the masking and social distancing guidelines, and whether that could potentially exacerbate this vulnerability, especially when it comes to vulnerable populations within the South, right? Because not only is the South as a whole in need of better rates of vaccination, there's still that disparity within, you know, across groups within the South, where that vulnerability can be exacerbated.
Yeah, so I think again, this gets back to two COVID nations. I think the recommendations they've made will probably work out okay in the New England states and New York, New Jersey, and California, but down here, I'm not so sure. And so there is, I mean, right now, the level of transmission's not so high, but I'm worried it's going to start going back up. And as good as the vaccines are, they're not perfect. So, there's two parts to this. You need people to get vaccinated, and that's going to dramatically reduce symptomatic illness and even asymptomatic transmission because it's stopping virus shedding from the nose and the mouth. But it's not perfect. So if you have a screaming high level of transmission going on, you're still going to see breakthrough cases. So, if things stay down, we may get away with it. But I think the South, again, is very vulnerable. I'd be really careful about relaxing those restrictions. Now, the CDC can talk all they want, but you've got governors down here in the South that, they're in their own world, right? So they're going to do what they're going to do, and they're basically opened up things completely, pretty much.
Yeah.
Can we touch on, you started off with good and bad news. Maybe let's touch on some of the great news, right?
Here's the bad news. The bad news is that was the good news.
So what about the Pfizer kids vaccine approvals? Maybe we can talk a little bit about that.
I was joking. There is good news. That's right. I mean, the among the adolescents, the vaccines look really good. Both Pfizer and Moderna. Now we just got the data this week from Moderna, and they're saying 100% protected, but it's pretty small studies. I don't think the 100% will hold up, but it's good, and it's not just the high protection; it's the level of virus neutralizing antibodies are looking really high as well, at least in the Pfizer. I haven't seen the Moderna, but probably the Moderna as well. And so they're going to be very, very effective. So that means if we can get all the adults and adolescents vaccinated, the fall school year is going to look really good, in terms of junior high schools, middle schools, high schools, right? We'll be able to, if the kids are vaccinated, teachers, the staff, bus drivers, we're good. That'll be, but again, you're going to have that issue. If the parents aren't getting vaccinated in the South, then the adolescents are going to get vaccinated in the South either. And
then you have some school districts in the South, Florida, excuse me, that basically are doing the exact opposite and are insisting that people don't get vaccinated.
That was crazy. That was because they said they were going to shed spike protein or shed virus. I mean, somebody buy these people a high school biology textbook, please. Yeah. I mean,
honestly,
really, like rudimentary biology, right?
Yeah. So, yeah, and also Moderna, I think they did report that it was like 93% effective in kids after one dose. So I'm sure once they get more data from that,
it'll be more robust with two doses, I think, and also the variants. Now, here's the other problem that I'm seeing. So my colleagues at Houston Methodist Hospital, which is just, I'm looking out of my window at it now. They have a good genomic virus sequencing program, and they've been doing a good job sequencing virus in Houston and Texas. And now what's started to happen is that B117 variant, which the vaccines protect really well against, is now acquiring a second mutation in the 484 position that makes it look like the South African or the P1. So that then means the vaccines won't work as well. So this is why we've got to vaccinate. We've got to stop the emergence of that sort of the B117 variant plus, because I really worry about that. So there's so many reasons why we need to vaccinate. And but again, this gets back to my original question, is that low vaccination coverage in the South? The graphs say it's mostly due to conservative groups, but I'm just curious your input. Do you think how much of that is still vaccine hesitancy in Black communities in the South as well? And we don't really have our arms around that yet. I haven't seen good social science data around that.
Yeah. Speaking of the hesitancy piece, I know just like with the J&J temporary pause, this week, a lot of parents, we got a lot of questions on Twitter from parents who are grappling with whether to take their kid for that second dose after the myocarditis announcement. And I wondered if you could just maybe put that in perspective for parents as well, in terms of give us perspective on the incident and whether it really is, a cause for concern.
Yeah, when we've last looked, it does not look like it's related to the vaccine. Or it's a very rare event. But myocarditis occurs in adolescence anyway. But back when I was practicing pediatric infectious diseases, especially as you got into the warmer months, you started to see myocarditis cases, because enteroviruses, which start popping up starting around now and into the fall, can cause myocarditis. So that's one possibility. The other possibility is COVID-19 itself, we know, causes myocarditis. And I'm wondering if, even after you get a single dose in the first few days, you're still susceptible to COVID-19. How much of that is due to COVID-19? So the numbers are looking like it's not associated, but we don't have it fully outlined. And again, the risk of COVID-19 among teenagers is a problem we're still seeing, especially with this B117 variant. I think part of the narrative that's out there is to say, well, the only reason you're vaccinating the adolescents is to protect the older adults. And that's not true. Yes, it's true that it will help protect older adults. That I'm not disputing that, but we're seeing a lot of adolescents get very sick from COVID-19, and then they'll come back and say, but look at the death rates. I said, well, things can happen other than death, right? You don't want your teenager going into a hospital or an intensive care unit with COVID-19. You don't want your teenager developing long-term debilitating symptoms, right? Shortness of breath, palpitations, exercise intolerance. This is not a time in their lives when they want to have exercise intolerance, right? They want to play sports and everything else. And then the neurologic symptoms, the brain fog, the depression. This is a bad disease, even beyond death. And people don't really have that understanding. And of course, the anti-vaccine groups just show these ridiculous charts showing the low death rates in adolescence. And that's true, but they obscure the other part of the story.
And also, we don't have enough data to find out what the determinative factors are for which kids are going to get sick and maybe even tragically perish, and which ones are going to
so you're right. So then the other part of the narrative is, hey, my kid doesn't need it. He goes to the gym, he plays sports. I said that's not the same as having virus neutralizing antibodies in your system from a vaccine, and that message needs to get through more. And the problem is the anti-vaccine groups just dominate the internet. I mean, it's great what we're doing, but we're outgunned. I mean, the Center for Countering Digital Hate, it's amazing. There's an organization called the Center for Countering Digital Hate, now estimates that the 12 leading anti-vaccine groups have 58 million followers on social media.
Wow.
I mean, come on. I mean, this is tough. So the other thing I wanted to just briefly mention also is what's going on globally.
Well, yeah, we definitely want to grab that. Before you go to the global question, I wanted to ask you, I've heard a lot of chatter about myocarditis and the incidence of it, and how a lot of kids don't necessarily go diagnosed with it until, late. And the fact that we have so much pharmacovigilance around these vaccine trials is allowing us to catch these things in kids that might not normally have been caught otherwise.
That's exactly right. And also, it looks as though the rates that are being reported among the kids that are vaccinated may not even be as high as the background rate of myocarditis among kids at that age. So myocarditis does happen. So I think I don't think we have the final word yet, but it's looking as though that the association is not going to pan out with the vaccine, which is great news. Mm-hmm. But I don't want to close the lid on it just yet. But that's not a reason to not vaccinate your kid.
Right. We already vaccinate our kids. Remember, guys, they have a whole shot record. Like, it's not out of the ordinary.
Right.
But now that we've covered all the folks who are resistant to vaccination here at home, I wanted to get into our discussion about global vaccine landscape and particularly the crisis in India. Diana, I wondered if you would start by telling us a little bit about your org and how you guys are sort of working to bring reliable testing and mobile vaccination units to vulnerable nations.
Thank you, Dr. Hudson. If I could just talk a little bit about our beginnings so that you can understand how it is I got involved in this in the first place. In March 2020, I saw the PPE supply chain and distribution was left to the governors and caused obviously a lot of chaos and competition between the states. And I knew that a centralized distribution effort was called for and would be more efficient. And this is something that project managers understand very well. So I approached a group led by Antonio Nieto Rodriguez, who lives in Spain and is the godfather or expert on the subject of global project economy. His group consists of more than 300 highly skilled professionals belonging to the top 50 thinkers, strategists, and people, project management professionals from the Project Management Institute. So I had this idea of a modified shipping container that would be preloaded with 3-month supply of PPE and had a two-way data transmission, and that these units would be dropped in hotspots and coordinated globally for something that resembled a simultaneous or close-in-time suppression. And it would be backed with a program with a framework of test, suppress, and control. I was able to acquire a high-performance team through this network, 12 of us at first, the co-founders, and we were all in different countries, and we set up PGI, and together we designed the Rapid Response Pandemic Unit. Thank you for displaying it on the screen. The Rapid Response Pandemic Unit we refer to as the R2PU. Our focus was on the vulnerable in the world, but it really hit me hard. Initially, it was with Lori Lightfoot in Chicago talking about the disproportionality of the Black and brown people dying. That was hugely alarming to me, and it was, and it is my purpose for seeking partnerships that have a similar focus.
Gotcha. So, Dr. Hotez, I know that this is something near and dear to your heart, and we know that you've been working on a few recombinant protein vaccine candidates for a while now. So I thought maybe you'd just tell us a little about like what was your motivation behind trying to get something out that would help people in the world that didn't have access to that supply chain logistics that we need for the mRNA vaccines.
Well, first of all, I'd like to congratulate Diana for her work. I think it's really important that we get this, and bringing things to the people is absolutely. We've learned how important that is. So, thank you for your work on that. Anything I can do to help, just let me know. One of the problems is we're just not vaccinating the world. The U.S. looked after itself very nicely, and so did the UK, and so did some of the Western European countries and Nordic countries and Israel, and the rest of the world is not doing well. Africa's a disaster in terms of essentially no one's getting vaccinated on the African continent. Latin America's, there's some pockets that are doing okay, like Chile, but most of Latin America is doing very badly. Same with Southeast Asia. We're talking, we need to provide about 5 to 6 billion doses of vaccines. And where does that come from? I mean, I think that's the big question. So the Biden administration is doing some interesting one-off things, right? They did some patent waivers, which are okay. And they said they're going to donate 60 million doses of the AstraZeneca vaccine if it's released through emergency use. They'll give it out, maybe 20 million of some of the mRNA vaccines and J&J vaccines. But look at the scope. If we're talking 5 to 6 billion doses, that's a drop in the bucket. And so the one thing we haven't heard from the Biden administration is a comprehensive plan for foreign policy around vaccines and vaccine diplomacy. What's the plan? I mean, where does 5 to 6 billion doses of vaccine appear? It's not going to appear by accident. Someone's got to make it. Someone's got to pay for it. And I think the U.S. has to have that leadership. And then, when I say that, the immediate pushback I get is, well, why does it have to be the U.S.? There's other countries out there. And I say, you're right. It's fair enough. But, when we've learned in modern history, if we want to get things done, and it's got to come from the U.S. That's how we defeated fascism in World War II. It's how we won the Cold War. It's how we scaled up antiretroviral drugs for the world. It happened through PEPFAR. It came out of the U.S. So it's not that the U.S. has to go alone on this. We have to bring in the other G7 or G20 countries. But if you don't have vision coming out of the U.S., things just don't seem to happen. And I think that's what I've been pushing hard. And I have even said I want Secretary of State Blinken to give an hour-long foreign policy speech saying, how we're going to vaccinate the world, give us some specifics. And I know they've got a lot on their plate right now with what's going on in the Middle East, and that's very tough, but I still think we have to figure out a way to do this.
Yeah, it's unfortunate that that is always the question, like, and people, we're so nationalists now, all of us across the world, because in simple terms, it's a battle of the species. That's why we should care about vaccinating the world. We haven't closed the airports. We're not closing the ports. That's why we have the Brazil variant, the
that you're
UK
absolutely right. I
variant.
mean,
like,
it's the right thing to do because of our commitment to humanity and our humanitarian underpinnings, but it's also in our enlightened self-interest. I mean, especially down here in Texas, I say, to some pretty hard-nosed business people, well, why are we doing this? Well, look at the oil and gas industry, right? It's great now. People can drive their cars and you can fly to Missouri and you can fly to California and you can fly to New England, but where else can you fly to? I mean, these are international businesses, and if you can't do business with Africa because of COVID-19 or Latin America or the Middle East, there's only so far you're going to get. So the economy now is starting to go up, but then I think it's going to prematurely plateau unless we can figure out a way to vaccinate the world. So it's not only the right thing to do, it's in our own humanitarian interests. And then, of course, I'm getting a lot of questions about the origins of COVID-19. And I just had a piece come out last night in the Daily Beast that, makes the case that, why I think it's most likely natural origins based on when the virus emerged. Some are saying this virus could have emerged in the summer of 2019. But it doesn't rule out that there's not a laboratory involved. And then I say that the problem is it's not, I don't think we can resolve this through U.S. intelligence and collecting U.S. intelligence. We have to have an outbreak investigation. We have to have epidemiologists and virologists in Wuhan, in Hubei province, collecting blood and virus samples from bats, from laboratory animal reservoirs, from domestic animal reservoirs, from people. We need, and interview scientists. This is not a quick thing to do. It's going to take 6 months to a year. And until we do that, you can do all of the, collect all of the intelligence you want, but it's not the same as doing an outbreak investigation. We'll see how people respond to that.
Mm-hmm. I thought that we would just do what we usually do and go back to our science really quickly so that you could kind of give our audience an understanding of how your vaccine is different. I'll just remind everyone that with COVID, it's the spike protein that the immune system is checking for here, the virus ID card. Then you make matching antibodies that lock right in like a key fits a lock. And then those antibodies can go and tag the virus particles to set it up for the assassins that then come along and in different ways, depending on how they're trained, destroy the cell. We've talked about how the mRNA vaccines like Pfizer and Moderna kind of use more like a cheat code to give your cells the information they need to make little pieces of the protein, and then you make matching antibodies to fight off infection. How the J&J and AstraZeneca is more like a Trojan horse, where you use a little harmless engineered virus to kind of sneak those codes inside, and then you make the little pieces of the protein to make matching antibodies to fight off infection. And then I thought maybe you could tell us a little bit about your vaccine, which is what we like to think of as more like a surrogate, right? Maybe because we're using, in your case, yeast, but you can use lots of other cell systems to produce parts of the protein and then inject that as a vaccine antigen. And then
that's perfect. It's ours is kind of old school, right? So even if you go back one there, back to the go back to the cheat code there. No, go back to the cheat code.
Sorry.
I like that. So what we're doing is, rather than giving the instructions to make the protein, we're actually giving the protein. We actually give a piece of the spike protein, so you make an immune response to it. And the way we do that is we genetically engineer the protein in yeast, And you might see yeast. What's that about? Well, it's the same technology that's used to make the hepatitis B vaccine. And the reason that's relevant is that's been around for decades, 30, 40 years. So whether you realize it or not, your infant, your baby probably got the hepatitis B vaccine. So it's got a great safety track record. It's actually the same process as making beer. Instead of the yeast producing alcohol, the yeast is producing the recombinant protein, and we purify it away from all the yeast bits. And it's a very effective strategy. It takes a little longer to make than an mRNA vaccine. So that's why we're not first out of the starting gate. But it looks like it's going to be almost as good in terms of inducing virus neutralizing antibodies, and it's cheap. We think we can do this for $1.50 a dose, and there's no end to the amount you can make. So we've licensed it to Biological E in India, which is one of the big vaccine producers. They're scaling it up to 1 billion doses, and hopefully we'll get some discussions with the U.S. government. Maybe they could have a role in producing the rest of it. And by the way, we didn't patent it because it's an older technology, so there's no patent restriction. We put everything out in the public domain. So in theory, anybody who wants to read one of our papers, download it off of PubMed, can make it,
That's awesome.
which is fine with us. I mean, our goal is we're not out to make money on this. We're out to help the world, and hopefully this will come in at the right time, because I'm worried. I mean, I don't want to let this thing go for another year before we vaccinate the world. There's real urgency there.
Dr. Hotez, we were hoping to get an update from you on the regulatory approval submission in India, and why it's so important to think globally about eradicating COVID. And I have to harken back to a comment you made about the U.S. during the Cold War.
Oh, you just muted out there.
You're muted. You're still muted.
Sorry. Your comment about the Cold War made me think about your recent publication where you talked about how during the Cold War, we put aside issues that, the U.S. and Russia were dealing with so that we could focus on polio and getting, the world vaccinated for polio, and how times have changed now. So, what's going to happen? What do we have to do now to get through and past these nationalistic ideologies so that we can get a global response to this pandemic to help solve this issue?
Yeah, I mean, what we've had the Russians and some of the Chinese manufacturers sort of bypassing all the international regulatory authorities like the World Health Organization or some of the stringent regulatory authorities in Europe and the US, and promote vaccines directly to countries. And the problem there is some of those countries just do not have what are called the pharmacovigilance mechanisms for monitoring them, the safety. Like, for instance, if you remember the J&J vaccine, we picked up that rarely it can cause cerebral thrombotic events. Rare, but the system in the U.S. was robust enough to do that. And same with the AstraZeneca vaccine. So the adenovirus technology has that issue that rarely you can get cerebral thrombotic events, which are serious, but fortunately it's very, very, very rare. Sputnik V vaccine, the Russian adenovirus, is also an adenovirus vaccine. Does it do it? There's no evidence for it, but on the other hand, a lot of the countries that are taking this up now because it's been promoted by Russia, they have no idea because they don't have the pharmacovigilance mechanisms in place to monitor it. So we've got to figure out a way to bring back our global governance. And I have a paper out today in JAMA about that with my friend Venkat Narayan at Emory University, restoring that system of global governance because it was working. And at the same time, we need to partner with countries better to build vaccines, because not only are no vaccines being delivered right now on the African continent, COVID vaccines are practically none, no vaccines are made on the African continent. And, we've got to build that capacity. We need to basically do what India has done, which probably makes more vaccines than any other country, and franchise it and figure out a way to have, we should be able to make vaccines in South Africa or You name the country, we should be, or Nigeria, there's that level of scientific talent that it should be doable. Latin America underachieves. So Brazil, makes some vaccine. Cuba a little bit. We've got to do better in Latin America. The Middle East, except for Israel, underachieves in terms of producing vaccines. It's not a question of money, right? I mean, Saudi Arabia, the Emirates, Bahrain, these are wealthy countries, yet no ability to make vaccines. So we're too dependent on the multinational pharmaceutical companies that do what they can, and they do provide vaccine for the world when they can, but we need better redundancy in the system. So that's what vaccine diplomacy is about, to look at how the US can work with other countries to actually put that infrastructure in place. And it's not just factories. That's some ways that's the least of it. It's the human capital. It's the training to know, because vaccines are more complicated than small molecule drugs. You have to know how to scale it up and how to do it under a quality umbrella with quality control and quality assurance and all the supply chain management and the National Regulatory Authority. It can take years or even decades to build. And that's part of the problem, because political leaders don't like those kinds of time frames, right? If you tell a political leader, well, over the next 10 years, ... they look at that and say, I'm not going to be around in 10 years. That's not going to be my priority. So it takes a certain vision to want to do that.
Yeah. Diana, I'd like to just come back to you with a question, in talking about other countries, and I'm curious about the logistical planning that's required, right, when you're trying to manage an interventional response on the ground. What does that look like?
Sure, Doug. If the first milestone would be to the delivery of the unit, and then which comes with operations plan and training material. But the units must comply with the local health regulations and be staffed by medical professionals. In some cases, only the unit is needed. In other cases, a partial or full program would be needed. And this is where project management professionals on the ground could be really useful. They would be helping with a management procurement, for instance, and resource management. This is the advantage of working with a global network of project managers. For a program to be successful, it is important to ensure that there is enough sample collection and laboratory sites like the R2PU, and that they're all integrated with the public health systems, data systems, and that key performance and prevalence indicators can be tracked. So on the screen we have on display, and just something what it would look like if the R2PUs on the ground in different parts of the world, communicating to a cloud and transmitting that data back to the health and governmental agencies to help them with decision making. So yeah, that's what we can do. The idea, and just a takeoff of Dr. Hotez is saying is, this is one of those things where it's not just about equity, but obviously this is a virus that is a threat to all of us until it is arrested around the globe. In other words, if it exists anywhere, it's a threat everywhere. So this is really more about self-preservation as well as equity. We can't get rid of the virus unless we do something that's globally coordinated. And so the idea was to do a 5-prong or 5 response using the R2PU to deal with this globally, and to try to do it in a somewhat simultaneous fashion for a robust suppression. Otherwise, it continues to slip. So this is what we can do. Really anxious to look at an opportunity to do it. This is just on display here is just to give you an idea of when we're mapping out the hot spots with those little blue and yellow things being R2PUs, how they can be rapidly deployed So if they're, and even with regards to future pandemics, if they were stored in readiness, hopefully we learned from this pandemic to have future readiness, and then we can deploy the units and do something in a simultaneous manner to suppress. This wouldn't be the answer end all. This would be in support of whatever the governments are already doing. And we're hoping at some point, Dr. Hotez, that we can coordinate our efforts with you, and that at some point this involves the WHO for a better global coordination.
Mhm. Dr. Hudson, what are the challenges? I mean, I hear you talk about the testing capabilities. I wonder, what are the challenges in mutant variant surveillance in places like India and Brazil and Africa?
Well, the problem is we haven't even figured it out in the US, much less the world. I mean, if you look at the percentage of variants that we're sequencing, it's really small. Now, the CDC has recognized this as a problem and they're trying to correct it, but we're still underperforming in terms of the percentage of virus isolates. You know, we should be doing a much higher, because that's our only way to know the full extent of the variants emerging. So that's a problem globally as well. And in the US, I can't quite understand it. We have more sequencing capacity than just about anywhere in the world. I mean, we've got these massive genome centers, including here at Baylor and the New York Genome Center and the Broad Institute at Harvard, MIT, and Washington University in St. Louis, University of Washington, and the California University. So why we're not doing this to full capacity? Those sequencers should be running day and night, sequencing virus, and I just don't understand why we've not fully tapped that. And that's the US, and then you can imagine, what are they doing in Paraguay? What are they doing in elsewhere in the world? But there is a lot of capability. It's just it hasn't been mobilized appropriately.
Diana, how are your units equipped for testing, and how important is that in the context of coordinating services for people on the ground in terms of being able to test prior to vaccination?
Okay, well, the R2PU is, as I mentioned, modified shipping containers. In the US, we use something that's not a shipping container, but a 16-footer because of the mobility and the logistics around storage. All of the designs, however, have data intelligence capabilities. The basic, or the very first R2PU that we developed or designed, as I mentioned, was for primarily preloaded with PPE for, to help with the PPE distribution, and for, as a command center for testing with testing and walk-up lanes outside of the unit. Those units have shelving, waste disposal, under-counter refrigeration and storage, and IT equipment, et cetera. Then we also, it became apparent while we were in the design phase that we were still not able to achieve suppression because the laboratories were backed up. So, and the test results were coming out too late. So then we went into design to design a mobile lab. And those labs are equipped with lab equipment, obviously, storage, freezer, refrigeration, and adequate storing and dispensing of vaccines, including Pfizer. Then we were looking at the vaccines coming about. It happened quicker than we anticipated, but we then developed what we call a hybrid, which is a mini lab, but it has two compartments, two patient compartments, two separate compartments for administering the vaccine. So these units can be used singularly or as components. They work well in a program that is both testing and vaccinations, which is something that we've looked at as a possibility for extending vaccines when they're in low supply, when you might test first and then wait later or calendar later those who test positive because they're already infected and have antibodies to get the vaccine at a later date. So that's something that we've looked at as a possibility for extending the vaccines where they're in low supply.
It's
Oh, I do want to add that one of the, I did say that it's not just the unit though, it is also that on demand, we can access the network of project management professionals around the world. PMI is an international organization, and so it is really helpful that that's something that we can tap into in support of the units.
I just, as we're getting closer to the end of our time, I wanted to see if you could give us some of your closing thoughts, Diana. And part of this, Dr. Hotez earlier mentioned that part of what this solution overall will need to look like is building capacity in some of these other in nations throughout the continent of Africa and in South America and in other places where it's not really a cost of dollars and cents, but maybe some other barrier to address to build the capability of producing vaccines in those different places. But what about from like an engineering and project management perspective, like yourself? So how should those individuals be invested in finding creative solutions to this kind of global crisis and working together to meet these kinds of challenges?
Thank you, Doug. I think the collaboration between project managers and scientists and people in the medical profession is really important because project managers are used to looking at processes, relationships, and power dynamics and barriers that impede the services, the provision of services. So, and some of the tools of the trades that we use enable us to identify root causes and implement, process improvements and track key performance indicators. And so these are things that I think prove valuable, especially when I looked at how things were managed here in the US in the earliest part of this pandemic. Project managers further have, other disciplines like IT and risk management, communications and stakeholder engagement. So this is really valuable when you have to work intimately in the community. And I think that's where the R2PU and PGI would be most useful in working with scientists and medical professionals, is to get on the ground and be useful in disseminating the right information, dispelling the incorrect information that's out there. Unfortunately, some of that coming from the highest level of our own governments. But this is something that I think is really useful. We have to be in the community, talking to the people, gain their trust, and understand exactly what their problems are, and not just assume that that we know going in and that we have the answers to all of their needs, because obviously it's going to be slightly different everywhere we go. So it's just dealing with it on a community level, I think, and just fully exercising our expertise, ours as project managers, yours as scientists, Dr. Hotez. We have to collaborate and all work together if we're going to succeed with this. I believe we can, but it's because of meetings like this and a full intent to do our best.
Mm-hmm. Dr. Hotez, can you leave us with your thoughts on, I guess as you were saying, the work that G7, G20 nations need to be doing to ensure global vaccine equity in terms of like the actual threat to our species, and how do we begin to start mobilizing and advocating for other scientists and medical professionals to join the cause, because it's really up to us, right? We're the ones that know what we need to do, and if we don't speak up and stand up, who will?
Well, I think we still have not had a sort of a frank accounting or enumeration of the scope of the problem, and people still talk about millions of doses when we need to be talking about billions of doses. So and we're not really hearing about a global roadmap for how we get there. And I think that needs to be better. And it's not really coming from the UN agencies. It's not coming from the U.S. government. So I think without a roadmap, it's hard to know what direction to go in. So I think that's the first thing that has to happen. Second, we are seeing this new level of anti-vaccine aggression, and that's also going to be a problem, and it's growing, and it's now directly translating into declining COVID vaccination rates, and it's happening initially coming out of far right-wing extremism in the U.S. and even white nationalism. I've been now attacked pretty regularly now by groups that identify themselves as patriots or white nationalists. They say, a whole army of patriots is going to come hunt me down. And I'm saying, well, why do you need a whole army of patriots? It's just me and Nan and the cat and Rachel. I would think, one patriot's enough, maybe two patriots. I don't know why you need an army of patriots, but there you are. And so the level of aggression's going up, attacking scientists, and it's not walled off to the US. We're seeing this now. We're seeing doses are expiring in Africa because of they're doing this and elsewhere. So I think those are the two pieces around vaccine diplomacy, articulating the plan and countering the anti-vaccine, anti-science aggression.
Well, we come to that point where unfortunately we have to wrap up. I can't thank the two of you enough, Diana and Dr. Hotez, for being here with us today. Again, thanks to our audience for tuning in for this important discussion. Dr. Hotez, you've left us a lot to think about beyond just the science of dealing with this pandemic. I think we all have to start considering the policies that are going on as well, and the politics behind the pandemic if we're going to really solve these global problems. And I think we recognize from this discussion that folks like Diana and the work that her group is doing are going to be an integral part of collaboration to make this a successful effort at ending this pandemic. So thank you again for showing up for us today. We always love having you, Dr. Hotez.
Well, as I say, on some days you're the only friends I got, so I really appreciate it, and you inspire me, and I so appreciate you doing this hard work, because communication, it's all about communication, right? And that's been the piece missing throughout this pandemic. So I really welcome everything you're doing, and Diana, good luck with all your important work.
Yeah. At Hood Medicine, we want to bring you all trusted individuals to provide you with the facts and information to allow you to make the decisions necessary to keep you and your family safe. Please follow us on Facebook, Instagram, and Twitter to support our effort, donate to our cause, or find out about our next events. Visit hoodmedicine.org, at hood_medicine on Instagram and Twitter, Hood Medicine Initiative, all one word, on Facebook. Thank you again. Stay safe, get vaccinated, and stay masked up. Thank you.